Good morning,
Good
sir.
morning, sir.
So we have finished uh, acute and chronic leukemias. After that, the next topic is plasma cell disorders. Okay, so this again is another very important topic which is often asked in theory also, in viva also, even in practical and later on in clinical subjects. When you'll be in the clinics, then also it is very important. Now, what is plasma cell? Any of you can you tell me what is plasma cell? Any idea? No. Okay. Plasma cell is a type of, yes. Okay. Plasma cell is a type of modified B lymphocyte. Okay. So from B lymphocyte, plasma cell is developed, and its main role is what? What is its role actually? Anyone?
Synthesize antibodies.
Okay, synthesizing immunoglobulins. If you say it is actually same, but if you say immunoglobulin, it sounds better. Okay, so you can say antibody also. You can say actually both are correct. So it basically synthesizes and secretes antibodies or immunoglobulins, and they are uh, formed from B lymphocyte. So they are basically modified B lymphocyte, and they secrete immunoglobulins or antibodies. Now these plasma cells may have atypical, maybe neoplastic. Okay, so accordingly there are different diseases. So the most important one is multiple myeloma, which we have to know in detail. Multiple myeloma, and there are some other diseases also. So we don't have to study about these, but be aware of these names. Okay, so Waldenstrom macroglobulinemia, solitary plasmacytoma, where there will be just a single, solitary means singles, single tumor of plasma cell, and another is monoclonal gammopathy. It basically it produces immunoglobulin, no? So gamma globulin. Okay, so that's why the name came as gammopathy. So different types of globulins are there, as you know. So gamma globulin, from that the name came as gammopathy, monoclonal gammopathy of undetermined significance, or MGUS. So these are the different types of plasma cell diseases. Among them, we have to study about multiple myeloma. So we'll come to multiple myeloma. So the term multiple myeloma comes from its tendency to make multiple holes, okay, or we can say lytic lesions in the body, especially in the bones. Okay, so you will see there will be multiple lytic lesions in the bone, and it also affects the bone marrow and nearby cortex. That's how the name came as multiple myeloma. So it affects bone and bone marrow. There will be lytic lesions in the bone, and also it affects the bone marrow, and that's why the name came as multiple myeloma. Okay. So this is a neoplastic disorder of the immunoglobulin producing single clone of plasma cell. So basically this is a clonal disease, because it is a neoplastic disease, so it is a clonal disease. So a single clone of abnormal plasma cell will proliferate and will lead to multiple myeloma. Now, as I already said, that the plasma cells are modified B lymphocytes, and the neoplastic plasma cells are known as myeloma cells. So these myeloma cells will proliferate. And as already said, that characterized by multiple lytic lesions involving the skeleton. So there will be multiple lytic lesions in the bone of different parts of the body, and they are basically due to proliferating abnormal plasma cell, which are known as myeloma cell, and they are clonal. Okay, so they are clonal means they are from a single clone. That's why they are neoplastic. So most of the neoplastic or malignancies will be clonal disease. Okay. So normal persons, they secrete all 5 types of immunoglobulin, What are the different immunoglobulin? Anyone?
GADEM.
Okay.
IgG,
Hmm.
AM, D, and E.
Okay, very good. So there will be IgG, M, A, D, and E. And in multiple myeloma, what happens is that particular abnormal plasma cell which is proliferating in a clonal way, so they will be produce a particular immunoglobulin. Okay, one particular single immunoglobulin will be in excess, and this immunoglobulin is known as M protein or M component. This M is for myeloma. Okay, M protein is M for myeloma. So most of the time this is IgG. Okay, so there will be increase in increase in single immunoglobulin in the serum, and most of the cases this particular protein will be IgG. In exam, don't get confused with the name M protein. Okay, we say M protein or M component, but it is not IgM. Okay, don't get confused about it. M protein or M component, this M is for myeloma, and mostly this is which type? This is IgG type. Okay, so that means what we are I'm just repeating the thing once again, that is these abnormal myeloma cells or monoclonal abnormal plasma cells, they secrete a single type of immunoglobulin, and that is known as M protein or M component. This M stands for myeloma, and this is mostly of IgG type. In some 20 to 25% it may be IgA, that is the second most common. Rarely it may be IgM or IgD or IgE. So commonest in most of the cases, commonest is G and second common is A. That you have to remember. The commonest is IgG and second common is IgA. Somehow during exam time, often many students tell that M protein is IgM. I am repeating again and again, that don't get confused with the word M protein. M protein is IgG. M is for myeloma. So commonest type is IgG and the second most type is IgA. M, D and E are rare. Now what happens is, normally the plasma cells produce different immunoglobulins. As you know, that one plasma cell, they secrete immunoglobulin to give the immunity to the body, so that this immunoglobulin or antibodies will go and they will destroy or help in destroying different antigens. Okay, whether it is a bacteria or some other proteins, so it helps in destroying different antigens, and thus they keep the immunity of the body. Okay, but in multiple myeloma, what happens, the abnormal plasma cell will be proliferating. Too many abnormal plasma cells, they will be monoclonal plasma cell, neoplastic plasma cell, and these abnormal monoclonal plasma cells, they produce excess amount of a single immunoglobulin. Okay, single type of immunoglobulin. Again, I am repeating, that is known as M protein, and mostly it is IgG. Okay, second common is IgA, and okay, second common is IgA. M, D and E are rare. So myeloma cells also may produce excess of kappa chains and lambda chains. Okay, kappa or lambda light chain. So one immunoglobulin, complete immunoglobulin they produce, which is mostly of IgG type, and also they produce some free light chains, kappa chains or lambda chains. Now these kappa and lambda light chains have low molecular weights. That's why they are known as light chains, and they are excreted in urine. As they are small in size, they can be filtered through the kidney and they pass into the urine, and they are known as Bence-Jones protein. This again is often asked. Again, when you will be studying a renal system or kidney in third semester, then again this is discussed. Okay, so Bence-Jones protein are a typical type of protein which is seen in urine in patients with multiple myeloma. and they are composed of kappa chain or lambda chains. Okay, so usually usually proteins are not filtered in kidney, so usually we won't see any protein in the urine in normal persons, and here in this these patients, as these benzose proteins are small in size, so they can be filtered through the glomerular basement membrane and will pass into the urine. Okay. Say for example, here we can see that this green color is normal. Okay, maximum will be albumin, and then other this alpha, beta, gamma, and all will be there. So this green color is normal person, and in multiple myeloma, usually this IgG will be very marked. Okay, IgG is very prominent. Now we'll come to what are the different etiologies. So basically all the leukemias, we don't exactly know what is the cause, but often different factors are sort of blamed. Okay, so different factors, we often say that they can have some role in initiating this leukemia, any type of leukemia actually. So sometimes we say radiation exposure, or maybe exposure of some other chemicals. So these are some are not that well proven, but there are different factors which are proposed that they may have some role. So first is radiation exposure. This already we said in leukemia, when we discussed about leukemia, then also we said that especially this huge radiation exposure, what happened in Japan, that atomic bomb explosion in 1940s. So that led to many leukemic patients. Many patients suffered from multiple myeloma, thyroid cancers, and all. So it is suggested that radiation exposure may lead to multiple myeloma. Similarly, there may be some exposure of radiation in those who are working in this nuclear weapon and in manufacturing sector. And radiologists, diagnostic and therapeutic X-ray, if it is done repeatedly in some patient, X-ray also may, if repeated X-ray, then that also may lead to some kind of more radiation exposure and may lead to leukemias and multiple myelomas and all. In workplace exposure, say for example, those who are working in metal industry, or those who are working in industry where benzene is used. So in those industry, we often see that they may have multiple myeloma. Especially in dietary, there may be high risk if there is increased intake of liver and butter, and low risk in those who are taking mainly vegetarian food. Yes. Okay. Anyone asked anything? Okay. Okay. So and there may be some precursor medical conditions. We said one of the plasma cell disease is MGUS. Okay, that is monoclonal gammopathy of undetermined significance. So sometimes in some patients, and they may not have any clinical feature, but there may be increase in one particular type of immunoglobulin. So that is called as monoclonal gammopathy or MGUS. Those patients may lead to multiple myeloma. And also sometimes if there is some viral infection and all, I mean some of these multiple myeloma patients give history of some viral infection. So these are not very well proven, but they are said that they may have some role in initiation of multiple myeloma. Now let us come to pathophysiology. This is important. Okay, this is asked. This is often asked, and this is important. This you have to remember. Now, what actually happens? Like if myeloma cells are increasing in number, then how that will lead to destruction and bone and lytic lesion in bone. So that is important, and you have to remember this. Now, in bone marrow, there are stromal cells, macrophages, osteoblasts, osteoclasts, and myeloma cells. Now, especially these myeloma cells, they produce interleukin 6. They produce interleukin 6. This interleukin 6 you have to remember. Now interleukin 6, what does it do? Now it stimulates more myeloma cells, it causes less apoptosis, and more proliferation of myeloma cells. So this is important. And these myeloma cells also secrete osteoclast activating factors. So they will activate osteoclast. So what is the function of osteoclast? They basically eat up the bone. Okay, so as you have already seen in you have already studied musculoskeletal systems, osteoblast produces bone and osteoclast eat up the bone. Okay, so these activated osteoclast, they cause bone resorption leading to lytic lesion. Okay, so interleukin 6 will cause stimulation of myeloma cells and less apoptosis and more proliferation. Okay, so myeloma cells will be increased in number, and these myeloma cell will secrete osteoclast activating factors, which ultimately cause bone resorption and lytic lesion. Now coming to the morphology and clinical features. Now adults more than 50 years mostly who are affected, as we have seen in say for example in CLL and CLL is most elderly, usually more than 60s or 70s. CML is somewhat same age group like multiple myeloma, 50s usually. Okay, so age group, again I am telling, age group is a bit important in case of leukemia. So remember that CML, as I earlier we said, in children, ALL, AML in young adult, CML is middle age, and CLL in elderly. Okay, so that order you remember. Okay, ALL in children, AML in young adult, CML in middle age, and CLL in case of elderly. So in multiple myeloma, usually the age group is like CML, so it is somewhat middle aged, and male will be usually affected a bit more than female, not much difference, but somewhat a bit more than female. Now as the bones are affected, so there will be bone pain. Okay, so there is a lytic lesion, and these lytic lesions are usually seen in different part of the skeleton, but commonest is in vertebra, ribs and skull. So these three you have to remember. Commonest is vertebra, also it is in ribs and skull. And grossly the lytic lesion will show gelatinous soft red tumor mass, and if we see microscopically it will show myeloma cells. Say for example, let me show you one picture here. Say for example, these are the vertebra. Okay, so vertebra, all the vertebra, this bone or the body of the vertebra is affected, and there is destruction of the bone, and there is lytic lesion. So these part, if we see grossly, it will show soft gelatinous red tumor mass. Okay, soft gelatinous red tumor mass, and here we can see multiple. This is in the skull. There are multiple lytic lesions. Okay, so we'll come back to this once again. So there are lytic lesions. Commonest is in vertebra. Also it is seen in ribs and skull. Grossly the lytic lesions will show gelatinous soft red tumor mass, and microscopically it will show myeloma cells. And as there are lytic lesions, obviously the cortex is becoming thin, and as the cortex is thin, the strength of the bone is reduced, and there may be pathologic fracture. It may be in vertebra, or it may be in ribs, or it may be in other long bones also. So there may be pathologic fracture. When we say fracture as pathologic fracture, when the fracture is because of weakening of the bone due to some other pathologic condition. Okay, so say for example, if there is any tumor, or if any metastasis to bone, or some lytic lesion in the bone, so that will lead to weakening of the bone, and that may lead to fracture. So that is known as pathologic fracture. So here the lytic lesion is because of multiple myeloma, and that will lead to pathologic fracture. Also there may be cord compression, means if the vertebra is fractured or compressed, then there may be compression on the spinal cord. Okay, so there may be compression of spinal cord, and there also may be osteoporosis that means less bone mass in the whole body. Okay, so there may be osteoporosis also. And as osteoclasts are eating up the bone, so there will be this calcium of the bone will come into the blood. Okay, so because of that there will be hypercalcemia. So hypercalcemia is because the calcium from the bone is being resorbed and will come into the blood. That's why there will be increase in calcium level, and it causes neurological manifestation. If calcium level is more, so there will be different neurological manifestation or neurological abnormalities. And there may be renal failure because two things. One is benzose protein will be secreted in too much amount, and this benzose protein may block. It may be so much in amount that it may even block the renal tubules. So renal tubules will be plugged or blocked by huge amount of benzose proteins. And also there may be amyloidosis, which is again very typical of multiple myeloma, that there may be amyloidosis. You have studied amyloidosis in first semester, right? So in amyloidosis can be seen in some other chronic diseases or chronic inflammation. So that is secondary amyloidosis. Here we may often see secondary amyloidosis affecting different organs, especially kidney. So because of that, the kidney function will be affected. Even here in practicals, there is one card of amyloidosis kidney in which the history is given as a patient with multiple myeloma. So remember that multiple myeloma patients may have amyloidosis, especially in the kidney. And also, as these plasma cells are abnormal, the immunoglobulin what they are secreting in huge amount, they also may not be functioning normally. Those immunoglobulins may be structurally abnormal, and that's why overall there will be suppression of humoral immunity. As you know that immunity is of two types. One is humoral, one is cell mediated, and this cell mediated is mainly by T lymphocyte, and humoral immunity is mainly by B lymphocyte and plasma cells. So these plasma cells, as they are abnormal, the immunoglobulins are abnormal, so the humoral immunity will be affected. So there may be repeated infection by bacteria, especially by Streptococcus, Staphylococcus and E. coli. Okay, so Streptococcus, Staphylococcus, E. coli, all these bacteria may cause infections in these patients. And also there may be primary amyloidosis or secondary amyloidosis also in these patients due to deposition of light chains, and the site is liver and kidney, etc. In blood you may find anemia and bleeding because the RBC may be low, the platelet will be low, and that's why. Okay, and because of huge amount of protein in the plasma, the blood will be very thick. Okay, so there will be hyperviscosity syndrome. So that means the blood will be sluggish, very thick, and the blood flow will be sluggish. Blood cannot flow freely. Okay, so that is known as hyperviscosity syndrome. Blood will be more viscous. So that may lead to again several other abnormalities, like there may be thrombosis, etc. Okay, so that is known as hyperviscosity syndrome. So in this photo we already saw that there will be soft gelatinous red tumor mass in the site of lytic lesions, like it may be in vertebra, it may be in ribs or skull. Okay, commonest is vertebra. And we'll see osteolytic lesions. Okay, you see here there are small round osteolytic lesions. Okay, multiple small round osteolytic lesions. So what are they called? There is a name for this. Okay, I'll come to that. Now if we do investigation, what we can do, first thing is to see if there is any lytic lesion is there in the bone or in the skeleton anywhere. We have to do radiography. So we have to do X-ray of mainly vertebra, ribs and skull, and also we can do of long bones also, and we'll see or we'll try to find out if there is any lytic lesion anywhere. Next we'll do serum for electrophoresis. In the blood, serum electrophoresis, and serum electrophoresis will show the different types of plasma proteins. Now in this case, what we'll see, anyone? Any of you? What will be seen in serum electrophoresis?
Gamma globulin will be elevated.
Okay.
PAR will be elevated.
Okay. So what we'll see is increased type of immunoglobulin, which is known as M protein, and mostly this is gamma globulin or immunoglobulin G. Okay. Second common type is IgA. Commonest type is IgG. And next, third point is we can see urine. So first is X-ray, next is blood, third is urine for Benzos protein. Okay, you can check the urine for Benzos protein, which will be elevated. What are Benzos protein? Any of you? They are kappa or lambda light chains. Okay, and erythrocyte sedimentation rate, because plasma proteins are increased, this erythrocyte sedimentation rate will increase, markedly increase. Serum calcium will markedly increase because calcium is because of bone desorption, calcium is being taken from the bone and it is coming into the plasma. Next is peripheral smear and bone marrow examination. We'll see what are the findings. So first is radiography. So X-ray of the skeleton, and here we'll see multiple sharp. This word is important. Punched out lesions or punched out defects, because they will be very sharp punched out defects. So this word you have to remember, punched out defects. And as we said, that commonest is vertebrae. We may see in other side like ribs, skull, pelvis, and femur, and any part of the skeleton actually. So this punched out word you have to remember. So this is a big single punched out lesion in the skull. We can see multiple like this. Here we can see there are multiple punched out lesion. Here you see so much in the right hand side photo. There are so many punched out lesion in this X-ray. Okay, so these are multiple punched out lesions in the skull. Here we can see there is involvement of the femur also. Okay, involvement of the femur here in the humerus. This is humerus and this is in the femur. Okay, this is again in the femur. Okay, here in there is pathological fracture in the shaft of humerus, because the lytic lesions, the cortex has become thin, and because of that the bone became weak and got fractured. Okay, so this is called as pathological fracture of shaft of humerus. Okay, now already we said in serum electrophoresis, normally we don't see that much increase in a single immunoglobulin, but here we'll see M band or M protein due to increased level of monoclonal immunoglobulin in the blood, and which is mostly of IgG type. Second most common is IgA type. Okay, so this is basically the same picture. Normally this is the serum electrophoresis, and here we'll see M peak of IgG. Next, we have to check Benzos protein in urine. Now these are immunoglobulin light chains, kappa or lambda, and there is a specific feature or characteristic feature of this Benzos protein. Now if we heat the urine in a test tube, then this Benzos protein will precipitate. That means it will form a coagulation or clot at the temperature of 40 to 60 degrees centigrade or Celsius, and after that if we heat it further, then it will be dissolved. So it redissolves at 90 to 100 degree. Even if we cool the test tube, then again it will reappear. Okay, so it will reappear and reprecipitate again at more or less 60 degrees centigrade. So this is very specific feature of Benzos protein. So if we heat the urine in a test tube, it will precipitate or coagulate and if we heat further it will be dissolved. Again if we cool, so again it will be reprecipitate. Okay, so this you have to remember. This is often asked in viva, that what is the specific characteristic of benzoate protein. So it precipitates, this temperature also you have to remember, it precipitates at 40 to 60 degrees Celsius and it redissolves at 90 to 100 degree. And if we cool the test tube and or the urine sample, then again it reprecipitate at 60 degrees Celsius. Now, erythrocyte sedimentation rate will be elevated due to increased level of immunoglobulin. Serum calcium is elevated due to bone resorption. Already you have said that. And now we will come to the peripheral smear and bone marrow. Now, peripheral smear, because there is increased plasma protein, so the background will be bluish in color. The background of the smear will be bluish and there will be increased rouleau formation. Now, what is rouleau formation? Rouleau formation means, here we can see all this several RBCs there in short clusters or columns. Okay, so they will be stacking like coins. So this is known as rouleau formation. Okay, again you see here, so these RBCs, this is in high power, these RBCs will stack to each other, okay, like a coin, okay, like coins. So that is known as rouleau formation. So increased rouleau formation, and WBCs may be normal or decreased, platelet may be normal or decreased, and sometimes, usually plasma cells are not seen in peripheral smear, but in these patients sometimes it may be seen. Okay, now if we see plasma cell in the peripheral smear, then we have to call it as plasma cell leukemia. Okay, usually it is not seen in peripheral smear. Even in multiple myeloma patients also, usually plasma cells don't come in the peripheral smear. But if it is seen in peripheral smear, and if the percentage is more than 20%, then we call it as plasma cell leukemia, which indicates poor prognosis, means it is seen in advanced disease. Okay, when the disease is more severe, then only these plasma cells will leave the bone marrow and come into the peripheral smear. Now, as we saw this, that in the background there will be bluish color because of plasma proteins, and there will be rouleau formation because of, again, because of increased plasma protein. Okay, so this rouleau formation means the RBCs will stack to each other and will form small chain of RBCs. Okay, so that is called as rouleau formation. Okay, if we see the bone marrow, it will be hypercellular bone marrow because it is a malignant condition, and that is because of increase in plasma cells. So these plasma cells will be high in number, and usually it has to be more than 10%. Okay, normal value of plasma cell is less than 3% in bone marrow, but in these multiple myeloma they will be more than 10%, and there will be sheets of plasma cells with variable atypia. Immature plasma cells we may find, and that is known as plasma blasts. So there may be plasma blasts or immature plasma cells, and there may be other variable atypia of these plasma cells. Now we have to know a few word or term which is asked again in viva. First is, what is plasma blast? Now plasma blast we call when there is a prominent nucleolus. Okay, in the nucleus, when there is a prominent nucleolus, we call plasma blast. Flame cell is when the cytoplasm is like flame or like red. Say for example, these are all plasma cells or abnormal plasma cells. Here we can see a plasma cell with two nucleus, so binucleated plasma cells. Okay, here also we can see all these are plasma cells. Okay, now we have to remember few terms. One is flame cell. Okay, here the cytoplasm will be more flame like or more reddish in color, and sometimes immunoglobulin can be collected in the cytoplasm like several clusters of immunoglobulin. Okay, so this is called as mott cell or grape cell, like clusters of grapes. Okay, so that's why it is called as mott cell or grape cell. Okay, this is a binucleated plasma cell. Okay, so these you have these terms again. I'll just repeat the terms once again. So plasma blasts when there is prominent nucleolus, flame cell if the cytoplasm is reddish, mott cell or grape cell is multiple bluish grape-like cytoplasmic droplets of immunoglobulin, and another two names are there, Dachar body and Russell body. If the immunoglobulin is collected within the nucleus, then it is called as Dachar body, and if it is a single immunoglobulin collection, single big blobs of immunoglobulin, and then it is called as Russell body. When I'll put up or upload the PDF or the slides, then I'll put up the photo also, okay, of Dachar body and Russell body. So these are asked: plasma blast, flame cell, mott cell, grape cell, Dachar body in the nucleus, and Russell body in cytoplasm. This you don't get confused, Dachar in nucleus and Russell body in the cytoplasm. Okay. So how we diagnose these patients? There will be one monoclonal protein which is known as M protein, which is mostly IgG. It may be in some patients IgA, but rarely it is IgD or E or IgM. Okay, and in the marrow the plasma cell will be usually more than 10% plus one of the following features, that is anemia, lytic lesions or osteoporosis, renal insufficiency, and increased calcium. Okay, anemia, lytic lesions or osteoporosis, renal insufficiency, and increased calcium. And how is the prognosis? Prognosis is variable. Generally overall it is not very good and not very bad. Somewhat patient will survive for around three years. So median survival is 3 years, and what you have to remember is cause of death. Usually most of these patients, there will be a lot of problems with the immune system. So immune system will not work properly and they will get several types of infections. What we said, what are the commonest organism which will cause infection? Any of you?
Staph aureus.
Staph, then
Streptococcus
and E. coli. Okay, Staphylococcus, Streptococcus, E. coli. So often these patients may have pneumonia, may have infections in other most common is pneumonia, but they may have infections in other organs also. So all these, there may be complications, multiple infections, and ultimately that may lead to death. Second common cause of death is renal failure. Okay, often these patients may have renal failure because there may be lot of immunoglobulins and which may lead to ultimately amyloidosis, and also benzose proteins will block the renal tubules. So because of that, kidney functions will be abnormal and patients may have renal failure. So with this we finish the multiple myeloma. Anyone, any doubt? Just raise your hand once. Let me see how many of you are there. It's around 15-16 students are missing. Anyway, okay, 76, 77. Okay, anyway, I'll just note down who are missing actually. This. Okay. Quite a few. Day on day. Okay. Okay. So with this we finish multiple myeloma and the leukemias. So after this we'll start with lymphomas. Okay. So lymphoma, as we said, that lymphoma is the malignancy of lymph node, and after this we'll start with lymphoma. So all acute and chronic leukemias and multiple myelomas we finish with this class, right? All of you okay? Then I'll close.
Yes, sir.
Okay. Anyone any doubt? Nothing, right? Okay. I'll upload. Somebody asked also. I'll upload all the PDFs today only. Okay. Then I'll close it. Thank you.
Thank you,
Thank
sir.
you, sir.